much of symptoms hypothyroidism produces other than resistant hypertension and possibly weight gain. So if you ask the patient a question, have you, without any reason, apparent reason, gained quite a few kgs in the last year or a half or so? Possibly do a thyroid profile. A simple blood test does not require fasting, and you will be able to diagnose hypothyroidism. Despite this protocol, there is an entity called white coat hypertension. What is this white coat? Long-standing hypertensive patients develop renal artery stenosis. It is atherosclerotic renal artery stenosis. And this can cause tremendous increase in the need of medications and resistant hypertension. So that Dr. Chopra may answer the first question. The second question of his is even more relevant, that patients come to our clinic for blood pressure once in 3 months, once in 4 months. And then we check a blood pressure after making them rest for 5 to 7 minutes in a quiet, air-conditioned room and take the first reading. If the first reading is high, we give another rest of 5 minutes and take another reading. Despite this protocol, there is an entity called white coat hypertension. What is this white coat? White coat is the coats which we as doctors wear, aprons as we call them. And in the olden era, a patient walking into the hospital and sees a person in the white coat reflexly develops 10 to 15 millimeters higher blood pressure than normal blood pressure at home. This is called white coat. And you will tend to label this patient as hypertensive in inverted commas, start treating the patient, or might feel that this patient's blood pressure is not controlled. And down the line, it walks in the home and therefore, all the international societies guidelines today, 2017 guidelines, European Society of Hypertension, Canadian Society of Hypertension, and American Society of Hypertension, they all say that home blood pressure monitoring is an integral part of diagnosis in the first place to rule out white coat hypertension. And then to educate your patient, if the patient feels that he's involved in his own care, he is taking his blood pressure himself 3 times a day, 2 days a week, one working day, one holiday, that is my practice, and brings the diary back to me at 2 months. He feels, yes, I am involved in my own care. I am giving my own data to my own doctor to treat me better. It works phenomenally on the psyche of the patient and also to the morale of the patient to get involved in his own care. He is enthusiastic to tell me that data. And moreover, home blood pressure recordings, if they remain high, I know that this patient's blood pressure is really, really not well controlled. Doctor, that day I felt my blood pressure must have risen. Not must have. He has the machine at his home. You can check it. Doctor, I felt my blood pressure had risen, but when I checked the machine, it was pretty normal. So the blood headache was possibly because of something else. And this is a very important information for the doctor. Ambulatory blood pressure is a step beyond home blood pressure. And what is it? It is a machine applied to your arm with a small pager-like device on the waist belt. And this machine is programmed to take blood pressure every 15 minutes in daytime and every 30 to 45 minutes in the sleeping period at night, automatically. So the patient can hook on the machine in the hospital, carry on home, do his all chores like going to the office, conducting meetings, conducting his professional activities, coming back home, watching television, reading a newspaper, except possibly having a bath. And that 24-hour blood pressure will tell us 3 important readings with the home blood pressure monitoring alone cannot give. And what are they? Very early morning surge of blood pressure, 5 a.m. to 8 a.m. This surge is responsible for strokes and heart attacks. And if not well controlled, with appropriate timely dosage of a drug late in the night in the patient's life, then possibly you are not doing any good to the patient. Second is, in the sleep, normally the blood pressure drops. And ambulatory blood pressure is the only modality to tell you whether my patient has normal dropping blood pressure or no dropping blood pressure at all. So non-dippers or reverse dippers, patients whose blood pressure rises during sleep are the worst candidates, and they need to be aggressively treated. So both these modalities are not exclusive, they are complementary to each other. And we, with Dr. Chopra, of course, and leading doctors in Delhi, we did an India heart study. The interim results are already out. And we came to know by applying home blood pressure monitoring that almost 10% of Indian population have masked hypertension. That is even worse, that their blood pressures are normal in the office, but very high at their own home. And why is that so? Nobody knows. World data also shows around 12% of hypertensives are masked hypertension. And when they come to doctor's office, paradoxically their blood pressures are normal, so they are not treated. And they land up in target organ damage like retinopathy, eye affection. Dr. Chopra said peripheral vascular disease like leg artery affection, or heart attack, or even a stroke, because they are simply not treated. And only home blood pressure monitoring will diagnose it. So I think these two modalities are very
I think it's a very important, Dr. Pandey has clarified all the points.
Now I request Professor Gurpreet Singh Wonder, who has come all the way from Ludhiana. I consider him as a guru of hypertension. He did a lot of work when he was in API. I think the first guidelines came in API on hypertension. He had a contribution. And recently, I read an article in circulation written by him and Professor C. Venkatas Rao. Very nice expression. I think he has tremendous experience on the guidelines for hypertension care in India. We'd like to have your opinion, sir. What do you think? Are the API, TS
beginning discussion on what guidelines are, because it's very important for the general public also to know that whatever medicines, whatever practices are used by doctors, they are based on huge number of studies, and what we call in medical terminology, they are randomized studies. And then once there are significant number of data that is available in thousands of patients, then experts sit in various countries and they formulate guidelines, as Dr. Chopra is saying, so as to guide physicians, so as to guide the general public as to what today we live in an evidence-based era. We do not live in an era when a physician could say, this is my experience, this is my feeling, this is my thought. We only act when there is significant scientific evidence available and those practices are to be adopted. Why guidelines? Just now Dr. Pandey mentioned there are American guidelines, Canadian guidelines. Why there was a need for us to have the Indian guidelines? Because Indians are very different racially. Genetically we are so different. Our seasonal variations are there. And our predecessors lived in famines. This data is now available from world over, whereas it was at one time considered that heart attacks are less common in third world countries. But today we know Indians who have migrated to various parts of the world, whether it is to UK, to Singapore, to Canada, there is data across the world that the vagaries or the end organ damage because of high blood pressure, that is heart attack, occurs 10 years earlier amongst Indians than natives of those areas. So we truly are a population where some of these non-communicable diseases are increasing in their prevalence. And it is now realized that as our population in India is aging, when in women and 67 years for males, it's not that we have reached the ultimate. Still our longevity of life is much less than the Japanese, than the Britishers, than even some other communities. But the public health measures have made a significant difference. And in that, high blood pressure, and that's the mission which has been taken up today, because it is the commonest non-communicable. What are communicable diseases are? Which are communicated from one, like malaria, gastroenteritis, which can be acquired from another person. Non-communicable diseases are 50% dependent on your genetic makeup, of which you cannot really do too much, but 50% is dependent on your lifestyle, on how you spend your life. how much salt you are taking, how much fat you are taking, whether you are exercising regularly or not, whether you are doing yoga, meditation, relaxation, whether you are getting obese, how much fat you are taking. And if you are having a healthy lifestyle, you will be afflicted less often with these non-communicable diseases, which includes high blood pressure, diabetes, coronary artery disease, brain stroke, and cancers. And today it is realized that in the low middle income countries, 70% of the deaths are due to non-communicable diseases. And that's the reason Dr. Chopra has taken this Mission India, so as to make people aware that these non-communicable diseases are now more common amongst Indians as our population is aging. So these Indian guidelines were formulated, and one thing very unique about Indian guidelines is that we talk about our dietary patterns. We take a lot of salt. Indians are a very high salt taking community. These papad, pickles, anything that is preserved, all these dietary elements are very high in salt. And then we add, our cooking is frying and we add a lot of salt. Any preserved food. Now we are acquiring Western diet. We are acquiring diet which is high in fat and which is preserved. And now this new culture has come to our country. People are eating at home. They are getting food from outside. Food that is prepared outside the home has 1.7 times more fat and 1.5 times more salt. So any food that you are acquiring from these new carry home groups that have started will all be supplying you food that is high in salt and fat. So we want Indian subjects. Another very important aspect in our Indian guidelines is what we realize, that there is a significant urban-rural divide. The prevalence of high blood pressure in the urban areas is something like 35%, but in the rural areas it is 25%. So just the simple lifestyle of a ruralite, our traditional Indian lifestyle exercise, and in case blood pressure does not come down, then they have to take drugs, and mostly these drugs are on a lifetime basis. A very important factor that we feel is poor compliance of, it has been touched upon by Dr. Chopra before also, patients do, because drugs have to be taken on a lifelong basis. And since high blood pressure does not cause any symptoms, a very important message that we would like to give under Mission India is people who have a blood pressure of more than 140 by 90, in spite of lifestyle modification, they need to be on pills. They need to be on regular pills by their general physician, whatever he thinks is best for them. But on their part, regularity of taking medicine is very, very important. We in India do not feel the American population has only 10% of Indians are present in rural areas and 20% of Indians in urban area who have high blood pressure have blood pressures controlled. Rest 80% of them do not have blood pressures controlled. And if through such messages we are able to come across to people, make them realize that high blood pressure is a predecessor to heart attacks, to stroke. Both these fatal diseases are a consequence of high blood pressure, and if blood pressure remains high for a period of time, it keeps damaging your arteries on an incessant manner, and the arteries get affected, and so fat deposits in these arteries. If fat deposits in heart arteries, one succumbs to a heart attack. If it does so in the brain arteries, the blood pressure can damage the brain arteries and one can suffer from strokes. So public awareness is a mission that Dr. Chopra has taken, and under this Mission India, it is our participate in your treatment actively. Just now Dr. Ponda was saying home blood pressure recording. Know what your pressures are. Actively participate in your blood pressure monitoring and be regular in the therapy so that the consequences, the end organ damage effects of blood pressure can be reduced in our public.
Patient of resistant hypertension. Yesterday you were discussing with me that there are 600 echoes done every day. It's amazing. I was alarmed, amazed to know the data, what information you were giving me yesterday. I have not heard of any institute in Delhi who is doing 600 echoes per day in a very cost-effective manner. I think it was very, very lovely information. And I'm willing to work with you in a big way to reduce the menace of hypertension in public. My question to you, sir, do you really see this entity function of the heart, and they go into so-called heart failure, number one. Number two, is heart failure different from sudden cardiac death? Because there is a little confusion in the public mind. What is heart failure, what is sudden cardiac death, and what is heart attack? Please define all the three terms in the public interest.
Thank you, Dr. Chopra, for taking, this initiative, India mission, because India is facing the triple burden of cardiovascular disease, high blood pressure, and diabetes. As Professor Wander said, more than 50% of deaths in India are due to these lifestyle diseases. The most important in the management of high blood pressure is acceptance. So first, patients or persons has to accept that I have a blood pressure, then only treatment will be successful. So acceptance is in success of this treatment. That is one of the things. And another important thing, high blood pressure, more than 50% of the population do not know that they have a high blood pressure. And those who have a high blood pressure and taking medicine, more than 50%, it is not under control. So this is one of the important awareness need to be created. Not necessarily hypertension should have a lot of symptoms in the first few years of life. So it will be silent as far as high blood pressure is concerned. Heart is a fascinating structure. It pumps nearly 6,000 liters of blood every day. Only to emphasize the amount of stress heart is taking, because heart is one which can never sleep. So it is used to pump against a pressure of 120 or 130 millimeters of mercury blood pressure. So when there is a high blood pressure, so what is the definition of heart failure? Heart failure means the pumping capacity or horsepower of the heart is reduced. It is not able to pump the blood effectively, so that rest of the body doesn't get the optimal quantities of blood. So that is the definition of layman's definition of heart failure. And heart failure has two components. When heart contractility or when the pumping of the heart is reduced, horsepower of the heart is reduced, we call it as systolic heart failure. When heart relaxation is reduced, we call it as a diastolic heart failure. And most important is, many are under the impression that heart function is 100%. Heart function is not 100%. Normal heart pumping function or pumping capacity is around 55 to 70%. So it is not 100%. So when one's heart is pumping against a very high blood pressure or resistance, in fact, one of the common reason for resistant hypertension is the patients or people resistant to treatment. People resistant to take medication is one of the common cause for resistant hypertension. When heart is pumping against a high pressure like 180 by 100 or 170 by 100 over a long period of time, as a result, heart enlarges, heart muscle also becomes thicker. This is exactly like if somebody is playing tennis with the right hand, playing forearm becomes very thick. If he is playing tennis with the left arm, his left arm forearm will be thicker. Like that, heart enlarges, heart weight also increases. Any heart, when the heart enlargement, enlarged heart is always, is bad as far as the patient is concerned. So the usual types of heart failure I have already alluded to. The symptoms of heart failure, because hypertension today is one of the important cause for heart failure, and an enlarged heart is more prone for sudden cardiac death. An enlarged heart is more prone for heart failure. So the symptoms of heart failure is exertion. When they start walking or when they start climbing, there will be a fatigue or a breathing difficulty, tiredness, and also there can be swelling of the legs. And most important symptom is when they are lying in the bed, after going to the sleep for a couple of hours, they get up with breathing difficulty. They are not comfortable lying flat. They are more comfortable sitting. That is one of the important nominal symptom of heart failure. And another important thing in a heart failure is early recognition of. One of the important cause of swelling of the leg is blood pressure reducing medicine. So one has to differentiate whether the swelling of the leg, because in heart failure there is excess retention of salt and water in the body, in addition to breathlessness, in addition to tiredness and fatigue. If there is a bleeding, mostly it is a symptom of heart failure. And another important thing in an heart failure is early recognition of heart failure is very, very important. And today we have very important investigation after physical examination. ECG is one of the important things that shows whether heart is enlarged, whether heart has become thicker. Then echocardiography is one of the gold standard for recognizing and confirming the diagnosis of heart failure. An echocardiogram is today is a very simple test, and we should also check for other blood tests such as for hemoglobin, because today 30 to 40% of Indians, more often from the rural area, they have a low hemoglobin. So correction of hemoglobin itself can relieve some of the symptoms of heart failure. Then you should also check for your kidney functions such as urea, creatinine and electrolytes. And another very simple test is there, what is called NT-proBNP. If somebody complains of breathlessness, fatigue, tiredness, these are some of the important basic symptoms of heart failure. And if this blood test is done, that will tell us whether this breathing difficulty is due to heart disease or whether his breathing difficulty is not due to heart disease. This is how we can arrive at a simple diagnosis. Another entity, we have what is called broken heart syndrome. Whenever there is a tragedy in the family, then there is a tragedy in your career. When there is a sudden shock, even an apparent, at that time blood pressure goes up, and some of these patients develop heart failure or almost like an heart attack like a thing, and ECG will be abnormal. And this is one of the most common cause of sudden onset of heart failure in a patient, in a person who are apparently normal. And most important, the anger is also one of the reasons for sudden rise of blood pressure and heart failure worsening. Results of anger are more painful than the reasons of anger. So results of anger are more painful than the reasons of anger. So definitely hypertension is one of the important cause for heart failure. Is already alluded to optimal control. Many a time what patients do when they are taking medicine, on medicine blood pressure is normal, and then on their own they stop thinking that, oh, my blood pressure is normal, let me stop. Then they come back after a couple of weeks, then blood pressure has gone high again. So one has to realize on medication, if blood pressure is normal, it's not truly normal. It is because of medication it has come to normal. And again, another important cause for heart failure, it has been already discussed, is obstructive sleep apnea, obesity, and in females, despite pumping capacity being normal, some of these patients can still have these symptoms of heart failure. Yes, definitely, this is one of the treatable cause of heart failure. If medication need to be taken, particularly water, and when a patient develops a heart failure, most important is salt restriction and water restriction, apart from some of the medicines that have been described. And sometimes high blood pressure can also cause irregular heartbeat, what we call it as atrial fibrillation. This can worsen heart failure. All of a sudden, when the heartbeat becomes faster and when becomes irregular, then it always it can precipitate heart failure. So this is how it goes. Then sudden cardiac death is one of the real problem. Apparently normal person with high blood pressure, I already said, heart enlargement or heart which is hypertrophied or heart muscle which has become very thick, they are more prone for sudden cardiac death. For this, there are some medications, there are some devices. So ultimately, 5 things are very, very important. 5 S's you can say, or 5. The first is we have to take care of these 5 S's. That is stress, then salt, then spirit, smoking, sedentary life. Probably then we can reduce this burden of hypertension and its related complications such as heart failure. And another important cause for heart failure in an hypertensive patient is the hypertensive or high blood pressure patients are more prone for heart attack compared to those with normal blood pressure. When somebody develops an heart attack, heart function can come down, resulting in heart failure. Heart failure is not synonymous with cardiac arrest. That I think heart failure, many people are trying to confuse heart failure and where cardiac arrest means heart stops, then it has to be revived, and some lucky one gets revived. In heart failure, patient will be alive, but he will not able to perform his routine physical activity.
I think to see whether the heart is functioning normally or not normally, that may help us to reduce the morbidity and mortality and keep us away from the heart failure. To my left is Dr. M.K. Das, who has come all the way from Calcutta. On a very short notice, he was in Patna. Are there or they are not there, they are all silent. Or you see when the patient comes to you only with the symptoms like organ damage. We like to have your opinion on this. Number 2, you put so many pacemakers or do so many electrophysiology. Do you think the management of these patients is a little different when they were registered hypertension, or the management is same? Dr. M.K. Das, sir.
I'm very thankful to Dr. H.K. Chopra for calling me on a very short notice to this particular mission India, which has been organized by IPCA. This is a very, very important mission to transmit the messages from the horse's mouths, that is the experts in cardiology. In fact, Cardiological Society of India started its journey in 1948. It was late Dr. B.C. Roy who was the founder president of this great organization. And the main idea was to send messages to the people, educate the doctors as well as the patients, and do research works in the field of cardiovascular sciences, which was in a very, very nascent stage in 1948. With the same mission, Cardiological Society of India is propagating the latest information to all the cardiologists and physicians treating cardiology patients, and also doing a lot of works to pass the messages to the people. He is organizing World Heart Day in a very, very big way. There are 27 branches, all of them are organizing the World Heart Day. And they are organizing seminars, symposium, where people are involved. And all of you have heard so many aspects of the development of hypertension and resistant hypertension from the different experts. What Dr. Chopra has asked me is whether there can be symptom or not. It's very interesting to tell you in a different way. In 2015, this is called SNAP registry for hypertension amongst the people in the whole country, where 182,000 people were screened at different cities in our country. And there, to our dismay, we found that almost 30% people are not at all aware about the existence of hypertension. So you can imagine what a high percentage of people are not at all aware, or in other words, they don't know the symptoms, or they don't feel about the symptoms. Now, why it is so? Why the symptoms are not there? There are many aspects of it. Definitely socio-economic factors are very, very important. As Dr. Wander was telling about the rural and urban divide, urban peoples are more educated, rural people are not. And at the same time, the sex is also very important, males and females. The females mostly, they ignore symptoms. Even if some grave symptom is there, headache, oh kuch nahi hai, ye aisa to hote hi rehta hai, mera mataji ka bhi hota tha. So that sort of ignorance, that sort of inertia, I'll use this word repeatedly, inertia, is very much there amongst the patients, and more so with the rural people, that they can't interpret anything. And that's the reason why the blood pressure and resistant hypertension are gradually increasing, because hypertension is just a starting process. It starts, then it perpetuates. How it perpetuates? As already highlighted, it affects most of the organs, the vessels, and the remodeling of the vessels ultimately perpetuate the process of hypertension, and that results in resistant hypertension at later point of time. So, what are the symptoms? Many times, हमारा जो पेशेंट लोग आते हैं, वो लोग बोलते हैं मेरा घबराहट हो रहा, घबराहट, and this घबराहट is such an important symptom for many diseases. I think Dr. Wander is an expert, because he is dealing with the Association of Physicians of India, where even in a book the definition of घबराहट was defined in a very, very different way and multiple ways. And घबराहट for us, the cardiologist and physician, is to some extent palpitation and discomfort, uneasiness, and this uneasiness is mostly ignored. Same way, headache, fatigue, breathlessness. As Dr. Manjunath was telling, the pressure, blood pressure, is an afterload. Afterload. You are pushing this hand, this is the afterload. If it is giving more pressure, my right hand cannot go forward. And same thing happens with the high blood pressure, more so with the resistant hypertension or very, very high blood pressure, which is uncontrollable. So, this kind of pressure afterload actually produces lot of diseases or lot of remodeling in the heart itself, and that heart cannot cope up and ultimately gives in different ways. Different ways means it can produce vascular disorder in the form of stroke, in the form of heart attack, in the form of kidney failure, in the form of peripheral arterial disease, that is the arteries supplying the distant part of the body, or in heart or to heart attack, then to the muscle damage, which is occurring due to the high blood pressure, that is the afterload, may cause sudden heart failure, which is also known as relaxation failure or diastolic heart failure. Same way, the abnormality occurring inside the musculature of the heart may give rise to irregular heartbeat, irregular rhythm disorder. So that irregular rhythm can cause sudden cardiac death. Not only the discomfort, palpitation, घबराहट. So the most important thing I would like to tell all of you, stitch in time saves 9. Stitch in time saves 9. So, if you can take care of the hypertension early, then automatically you are preventing the many diseases which have been highlighted. Now, next question was whether the different kind of device therapies or different kinds of pacemakers or these kind of things are there or not. The answer is yes. But what have been said by all other experts, they must be ritually followed not only by the physician but also by the patient. I always highlight this particular aspect, inertia of the doctor and inertia of the patients ultimately result in inertia-mediated hypertension, which I would call as resistant hypertension. So, first thing is lifestyle, drugs, and all this will have to be followed. There is no doubt about that. Only when they are really resistant to the drugs, lifestyle measures, and all the sleep disorders have been corrected, salt intake have been corrected, then only we'll go for certain special kind of therapies. One of them already, as a passing comment, was made like renal artery stenosis. That renal artery stenosis can be taken care of by 2 modes of therapies. One is the angioplasty of the renal artery, where the renal artery circulation is allowed to make more, and thereby it influences to some extent, not in all patients, to some extent, lines which I have written. It has been published in Indian Heart Journal. Give thy hands is the name of the poem. So the 2 lines are, give thy hands, give thy hearts to whosoever. Give thy hands, give thy hearts to whosoever. Enjoy the life, enjoy the heart, enjoy your heart forever. Thank you very much.
Dr. Vivek Kumar, I have just one question. How should we investigate this patient of resistant hypertension? What should be the message for people? Everybody should know. Because we discussed where is the resistance, maybe in the blood vessel, maybe in the biochemistry, maybe in the faulty methods of blood pressure measurement, maybe in the mindset. Whatever may be the cause of resistance or resistance in the blood vessel, how should we investigate? 2 things are mentioned by Dr. Pandey. Home BP one thing and by ambulatory BP one thing. What are the other methods by which we can say he is the patient with a resistant hypertension and these are what the complications he has so far? Number 2, you do so many interventions, sir. Coronary interventions every day, lot of MI, lot of acute coronary syndrome. Do you come across resistant hypertension quite often? And do you feel that the outcome of these patients is different as compared to those who are?
For inviting me and IPCA and Fan Health for making this event happen. At the outset, I would like to say that the questions about resistant hypertension is really pertinent, and in a country which is grappling with acceptance of disease of hypertension, you can imagine the resistant hypertension is something which has gone into something where people don't talk much about it, because we are putting a lot of effort to convince the patient that look, you have got high blood pressure and you must start the treatment. Now the question comes that those who have accepted that he has or she has hypertension, despite, as it was elucidated before also, despite maximum tolerated or guideline-based medication of 3 medicines, including 1 diuretic, the patient continues to be hypertensive. And when we define resistant hypertension, we are not talking about pseudo-resistant hypertension, or we are not talking about miscalculated or wrong reading. When we are saying resistant hypertension, we have excluded that, meaning thereby that we are getting, including the home monitoring of the blood pressure, the 3 readings of average with Cerca blood pressure instrument does. We also have to take the help of ambulatory, 24-hour ambulatory blood pressure monitoring. And once we are sure that the person is having blood pressure consistently more than 140 by 90 despite 3 medications, the maximum tolerable dose, then we have to label them as resistant hypertension. The history goes back when the simplicity trial for renal denervation therapy was started, and you would know there were 3 simplicity trials, and there the definition and the medications for resistant hypertension was defined in different trials. In fact, simplicity 3, the data went up to 5 antihypertensive agents. The patient had to be on 5 antihypertensive agents, and including one diabetic, which is spironolactone, and then only we have to label them resistant hypertension. Resistant hypertension is menace, and it can cause all the target organ damage, because we know from data that if you decrease the blood pressure systolic by 2 millimeters of mercury, then you can decrease the cardiovascular event stroke rates significantly lower. So there is no denial in fact, and if the person continues to have resistant hypertension, then we have to beyond what we call go beyond pharmacological agents. So the person has to be, so sometimes we see the lifestyle modification has not been adequately imparted, so you can't have very well controlled hypertension or in a patient who is not compliant with salt intake, exercise, and the adequate sleep, and sleep apnea has also been included in that. So I think these are certain 5-6 reversible causes which can bring in them in a comfortable zone. As far as the intervention in these situations are concerned, after the negative data from Simplicity 3 trial, it's not a guideline indicated treatment, but still there are many countries, especially in Australia, where this therapy is still going on in patients who are having resistant hypertension, and also to decrease the pill burden in them. Then the target organ damage is very, very important, and we need to educate our patient and the society that control of hypertension is one thing which can bring down the health budget of all other diseases significantly low. So we have to invest in one disease, that is hypertension, and then you can see the decreased number of CKD patients who are having dialysis, and also people who the ICU burden of heart attack will come down. So I think this is, if we ask the healthcare policy makers, then we need to convince them that this is one disease where they have to invest maximally, so that the other diseases healthcare burden comes down significantly. Then as you said, in our current practice, whether when we are doing so many coronary interventions and devices, the incidence of resistant hypertension. So I think all of us sitting here would agree that being in a tertiary center, we tend to get more resistant hypertension because we get reference from